hear some from your. Now I am at the session. Now actually today's topic in masterclass is approach to ascites. Ascites is an important disease encountered in day-to-day clinical practice. The cause may be due to decompensated cirrhosis, which constitute about 80% of total cause of ascites. Other causes are tubercular ascites, malignant ascites due to heart failure, cardiac ascites, pancreatic ascites, chylous ascites, etc. Now I invite Dr. Sujit Chaudhuri, who needs no introduction, is a renowned gastroenterologist who had lots of contribution in gastroenterology, having many papers in national and international journals, monograms and books. Dr. Sujit Chaudhuri, please, to start the seminar on approach to ascites.
Good morning to everybody. I am very much pleased to be present in this masterclass, and I must thank the API West Bengal chapter for giving me this opportunity to speak in this forum. So first, at the outset, I must thank all the my senior colleagues who has invited me and also as giving me this opportunity. I will be very happy if my colleagues, my friends, and my students, particularly those who are doing postgraduates, will be benefited by this scientific discussion on the management of ascites. Etiology, the clinical features, investigations, and the management. So ascites is a common problem, clinical problem. It is managed by the physicians, gastroenterologists, even sometimes the surgeons, gynecologists, the other specialists also facing the problem of ascites. So how to evaluate ascites, I will discuss. Before that, that is a internationally accepted grading for ascites is mainly for the cirrhotic ascites, but you can grade it in other form of ascites. So the older classification was grade 1 to grade 4. When there is massive and tense is grade 4, but the International Ascites Club is graded the ascites, mainly cirrhotic ascites, when it is just mild, which is detected by ultrasonography, is grade 1. But the moderate ascites and there is clinically evident ascites is grade 2. But when there is a gross ascites and significant abdominal discomfort, and that is grade 3 or large ascites. So before going further, just what are the causes of ascites? The cirrhosis is the commonest cause of ascites. And throughout the world, anywhere from the different countries and in all the epidemiological data shows that most commonest cause of ascites in cirrhosis in the West, about 75 to 80% is due to cirrhosis. I will discuss about our Indian data. Among these, other that there is without cirrhosis, sometimes alcoholic hepatitis, acute hepatitis can produce ascites. And the other causes are heart failure, malignant ascites, that is peritoneal carcinomatosis, or when there is massive liver metastasis. And about 5% patients of ascites can have mixed ascites. Commonly, there is a cirrhosis with another cause of ascites. Rarely, ascites can be due to pancreatitis, nephrotic syndrome, but tuberculous peritonitis is an important entity, particularly faced in our country and also in the other Asian country where tuberculosis is very common. And about 5 to 10% of ascites can be due to tuberculosis. Acute liver failure, as mentioned, that can be. And if there is hepatic venous outflow obstruction, that is Budd-Chiari syndrome, can produce ascites. Sinusoidal obstruction syndrome, post-operative lymphatic leak after surgery, and really hypothyroid can produce ascites. So this is Western data that commonest, about 75 to 80% is due to cirrhosis, and about 15%, about 10 to 15% is due to malignancy. 5% can be due to heart failure. In West, tuberculosis is only 2%. But in our country, there is some data that cirrhosis is about, this one study from the West and the another study from the South. It depends, according to this is only the tertiary based hospital data, so that the about 14% is TB and about 58, that is 60% is cirrhosis, and the other causes are cardiac and renal, and malignancy is in the tune of 10 to 11%. So in our country also, we should think that cirrhosis is the commonest cause, followed by malignancy and then tuberculosis. And differently according to the prevalence, tuberculosis or malignancy, but the commonest is cirrhosis followed by malignancy. So how to approach, you should take the history and then the physical examination. The history, that is the symptoms. The ascites is maybe, that is when due to the fluid accumulation, there is some discomfort in the abdomen, abdominal distension and weight gain. And the other, according to the etiology, then you have to go for other symptoms, like when there is symptoms suggestive of any liver disease or malignant disease, systemic symptoms of tuberculosis, that you have to assess. And regarding the physical examination, the clear ascites, that is the obvious distension of the flanks. And then I will discuss that the most important clinical finding is shifting dullness. But when you are seeing the patient, you should also search for the signs for liver disease, that is whether any seizures or suggestive of chronic liver disease like pulmonary erythema, the jaundice, spiders, and there is muscle wasting, and also abdominal examination, there is splenomegaly, and the left lobe of the liver is palpable and formed. And if you suspect the cardiac cause of cirrhosis, then there is a prominent jugular veins, presence of hepatojugular reflux, there may be peripheral edema, and there may be some gallop in the heart by cardiac examination. The signs of IVC obstruction, you should search that whether there is prominent back veins with the direction of flow from below upwards. And if you are suspecting that there may be some finding which may suggest malignant ascites, if there is some nodule around the umbilicus, that is called Sister Mary Joseph's nodule, and there may be some lymphadenopathy, particularly varicose gland may be palpable. So these are the clues by which you can suspect what can be the cause of ascites. Shifting dullness, this is the most important clinical parameter by which you can be confirmed that there is free fluid in the abdomen. So how to elicit it? That you should percuss the abdomen from the central part to the flanks. And usually the central area will be by percussing the flanks, there will be a transition of air of fluid can be identified when the percussion note changes from the tympanic to dull. So when that you have to identify, the central area is tympanic and the flank is dull. And then you roll the patient to one side and then you percuss as before. So area of tympanic node will shift towards the top, and that is called the shifting dullness. So this is the dull area and this is the tympanic area. But when you are shifting the patient to on the side, then you are again percussing, the shifting that is increased. So that is the shifting dullness. Then the imaging. The most important and the first step in the diagnosis and also evaluation is the abdominal ultrasonography, by which you can have an idea how much significant ascites, whether it is a loculated ascites, whether there is some finding suggestive of cirrhosis with portal hypertension, portal vein diameter. You can assess, and along with that, you should do the Doppler study also, whether there is any evidence of hepatic vein obstruction or IVC obstruction. So the most important step is abdominal ultrasonography. But sometimes you have to go for CT scan of abdomen. And this CT scan of abdomen is more sensitive and specific for diagnosis of cirrhosis. But and a CT compared to ultrasonography. But particularly if you suspect that there is some complications of cirrhosis with if there is a malignancy, particularly hepatocellular carcinoma, the CT is more sensitive and specific than ultrasonography. And also, if you suspect malignancy, there may be the features of lymph nodes, and even in tuberculosis, thickening of momentum, and the lymphadenopathy that can be assessed by the CT scan. So this is the picture, very suggestive that there is no second diagnosis other than cirrhosis, that there is free fluid in the abdomen, liver is shrunken, the margin is irregular, there is no SOL, but so this is sensitivity and specificity is higher. Then the next step in the evaluation of ascites is diagnostic paracentesis. The paracentesis should be done in the for the first evaluation of ascites. So in a new onset ascites, you should not avoid this step. This is very important. And the diagnostic paracentesis is a very simple procedure, safe procedure, and it can give you a lot of information for the diagnosis and further evaluation. And in patients of cirrhosis who are getting admitted to the hospital, again, you should go for paracentesis of ascites, mainly to exclude spontaneous bacterial peritonitis. And well, in the patient of cirrhosis, if there is clinical deterioration or fever, then you have to do. There is no contraindication for diagnostic paracentesis of ascites. This is a technique by which you should puncture the needle for paracentesis. That is called jet track technique. How you will do that? There is a ascites, and if you put the needle directly, then there is a track will be there, then the leakage of fluid may be higher. But if you do the jet track technique, the leakage will be less. What is the mechanisms? Just you pull the skin downwards with the other hand, that is with the finger. So we are pulling the skin and subcutaneous tissue to some extent. Then you are puncturing the needle straight away. So, and then after removing the fluid, when you will be the skin will be pulled, so the track for the inner wall of the abdomen is here, and the puncture for the outer wall is there. So that is a jet track, so that the puncture sites are overlapped, so the leak of fluid will be minimal or nil. So this is very important. What are the complications of paracentesis? They're almost nil, very rare, and there may be mild local hematoma. There may be some amount of ascitic fluid leak, particularly when you are doing large volume paracentesis with a wide bore needle. Rarely, if you puncture a vessel, there may be hemoperitoneum, very rare, less than 1%. And bowel perforation less than 0.0, it can produce infection. This is also very rare. And mortality less than 1 in 1,000, particularly if there is bowel perforation. So usually it is a safe procedure. And one important issue, that whether there is no contraindication if there is coagulopathy or low platelet count. You know that in cirrhosis, the prothrombin time may be high, the platelet count may be low, 50,000, 30,000, but there is no recommendation that you should give prophylactically fresh frozen plasma or platelet transfusion before doing this procedure, because the complications of this procedure is very rare. And you know, the coagulopathy in liver disease is very difficult to predict, because in liver there is both fibrinolytic system and thrombogenic systems, are all the factors are diminished, and the parameters, this guide, prothrombin time, is not a good guide for assessing the bleeding risk in patients of cirrhosis. So paracentesis, for doing paracentesis, there is no indication that there is no contraindication if the patient is having high INR and low platelet count. The most important, so I have already mentioned that this is, I should skip this. So what are the tests you should do? The routine analysis. You should give a good, gross appearance of the ascitic fluid. What is the color and what is the appearance, when there is formation of coagulum, whether it is a milky or not, that you suspect that whether it is a chylous ascites. Then the total protein should be estimated, and albumin should be separately done when your ascitic fluid albumin test should be done, and simultaneously you should send on the same day the serum albumin should be done to have an idea of the serum ascites albumin gradient and the WBC count and the differential count, and you should send the ascitic fluid for culture. And then these are the routine tests and the focused analysis, that cytology in suspected malignant ascites, amylase for suspected pancreatic ascites, and for tuberculosis, AB stain and culture and ADA. Triglyceride you should do in suspecting chylous ascites. If there is the fluid is dark color or reddish, then whether it is a traumatic TAP or hemoperitoneum, you have to differentiate, and the RBC count should be done, and you should the fluid should not coagulate if it is due to hemoperitoneum, but if it is a traumatic, the clotting will happen. And the bilirubin in suspected obstructive jaundice. Glucose and LDH should not be done routinely, but if there is a secondary bacterial peritonitis and significant sepsis, then the glucose will be low and LDH will be high. Most important thing that I should reiterate, that the CA125 test, either in the blood or in the ascitic fluid, should not be done, because this is elevated when there is distension of the abdomen and there is mesothelial cells activity is high, and falsely it will be high. So in a suspected case of strong clinical suspicion of ovarian malignancy, then only the blood test for CA125 should be given, but otherwise ascitic fluid and blood CA125 in the evaluation of ascites should not be done. What I mentioned, that ascitic fluid albumin gradient, and that is that you are abstracting the serum albumin and minus the ascitic fluid albumin. That if the gradient is more than 1.1, that indicates that it is sinusoidal hypertension is there, and sinusoidal hypertension means liver disease, cirrhosis, or other causes, really heart failure and other causes, constitutive pericarditis, IVC obstruction. Then there is sinusoidal, hepatic sinusoidal pressure is high. That indicates that high SAG ascites. But in the protein, that is serum ascites albumin gradient is less than 1.1, then it is a peritoneal disease, either tuberculosis or peritoneal carcinomatosis, or in case of pancreatitis, rarely due to nephrotic syndrome or cirrhositis, then the low SAG ascites. So this is the most important test for assessment. And when a patient of new onset ascites, diagnostic paracentesis, I have mentioned that SAG should be done, and if it is more than or equal to 1.1, and then ascitic fluid is less than 2.5, that suggests cirrhosis. But if there is a ascitic fluid protein is high, more than 2.5, then it indicates that it is a post-hepatic process, either cardiovascular disease or that is or hepatic vein obstruction. Then you should do the Doppler study and cardiac ultrasonography. But when it is cirrhosis, and then you can further evaluate by CT scan or endoscopy for varices and other functions. But in patients, when there is a diagnostic dilemma, in particularly patients you cannot differentiate, then you have to go for hepatic venous pressure gradient or transjugular liver biopsy. I will go for that hepatic venous pressure gradient is an important parameter by which you can differentiate that whether the ascites is due to sinusoidal or post-sinusoidal, or it is a peritoneal. And but if the SAG that is less than 1.1, that investigate for the peritoneal process, that is cytology, AFB and ADA and CT scan, and and after that may need laparoscopy and peritoneal biopsy, both for the diagnosis of tuberculosis or malignancy. This is the important test for evaluation of ascites. So by that, OH hepatic venous is not routinely practiced, but sometimes you need to do this test for having an idea for the hepatic sinusoidal pressures, free hepatic venous pressure, and then that is called hepatic venous pressure gradient. That is OH hepatic venous pressure minus free hepatic venous pressure. In cirrhosis, the hepatic venous pressure is high because of sinusoidal hypertension, but the free hepatic venous pressure will be low. So gradient will be high. And if when the development of ascites occurs, when this gradient is more than 12 millimeter of mercury. Normally it is about 5 to 6 millimeter of mercury. In case of cardiac cause, both the OH hepatic venous pressure and the free hepatic venous pressure will be high. So gradient will be normal. But in case of primary peritoneal malignancy or TB, all of the parameters will be normal. So the additional test I have already discussed. I don't want to this. So ascitic fluid culture. This is an important step when you are suspecting a case of spontaneous bacterial peritonitis. The spontaneous bacterial peritonitis is a complication that is infective, the complication of cirrhosis. And this bacteria in the ascitic fluid is very scanty. This bacteria is coming from the intestine as a bacterial translocation. And so it is just like when we are, the yield for bacteremia in the blood when there is an infection is very low and we are doing the blood culture. So for that, the ascitic fluid, if it is inoculated in the bedside in a blood culture bottle, the yield for the positivity of culture will be higher. So the yield for common conventional technique, the yield is only, in one study this is found 40%, but it is less than 20%. But if you do bedside inoculation, it can be as high as 80%. So, and this is a picture that was showing that polymicrobial, that there is a lots of cocci, bacilli in a culture, in the peritoneal fluid, gram stain. This is a gram stain of peritoneal fluid. So if it is a polymicrobial infection, that it indicates the secondary bacterial peritonitis due to a ruptured viscus. The tubercular peritonitis, you should do the smear. The AB smear is only positive in less than 1%, only 1 to 3% cases. So it is rarely positive, but you should do the culture, that is the conventional culture or rapid TB culture. The cell count, predominantly lymphocytic. The adenosine deaminase test, that is the most sensitive test for tuberculosis. And this is due to it is coming from the lymphocytes. And there is a cutoff value, and if it is about 39 to 40 international unit, that the sensitivity is about 97% and specificity is about 97%. So ADA is a very important sensitive test for the tuberculous peritonitis. And I mentioned that if you suspect, then you have to go for peritonioscopy and biopsy. And the newer method you can utilize like GeneXpert by the nucleic acid applications test from the ascitic fluid and also from the tissue, that is culture. So now that is the most important part of my discussion is how to approach a patient of cirrhotic ascites. As I mentioned that as cirrhosis is the commonest cause of ascites, that just I want to discuss about few points about the pathogenesis, then the therapy, and the problem of difficult to treat ascites, that is refractory ascites and spontaneous bacterial peritonitis. The pathogenesis of cirrhosis is, there are a lot of theories earlier, but the latest concept is the most important. Because of the portal hypertension, there is splanchnic vascular dilatation, splanchnic vasodilatation. And when there is splanchnic vasodilatation, there will be an arterial underfilling. That is when there is an arterial underfilling, but in the kidneys, then there is activation of the vasoconstrictor mechanism, renin, angiotensin, aldosterone system, and also later there is this activation of atrial diuretic hormone, ADH, also known as the activation of antidiuretic hormone. So, and along with that, when there is splanchnic vasodilatation, there is increase in the splanchnic capillary pressure is high. So there is outpouring of lymphs. So this is the mechanism by which the ascites formation occurs. When there is activation of these renin, angiotensin, aldosterone mechanisms, there is retention of sodium and water from the kidney. And the retention of so the total body sodium is always high in patients of cirrhosis. And when there is sodium is avidly reabsorbed because of the activation of the renin, angiotensin, aldosterone mechanisms. And the sodium retention is the main mechanism for ascites development along with the portal hypertension. So for this process of splanchnic arteriolar vasodilation, the present theory, there is activation of both these molecular associated, that is pathogens, associated molecular pathogens, and the damage associated molecular pathogens. So there is activation of the pattern recognition receptors, and which release of different reactive pro-inflammatory mediators. And so there is splanchnic arteriolar vasodilation. And for this, there is arterial dysfunction, adrenal dysfunction, hepatic encephalopathy, renal dysfunction, and even hepatopulmonary syndrome. All these end organ dysfunctions occurs as a mechanism of this splanchnic arteriolar vasodilation. Those in cirrhosis, so I have already mentioned that is in a progressive manner. Initially, in the first step, there is ascites formation, and then there is gradually sodium retention is high, and there is refractory ascites. When these splanchnic vasodilation is profound, then there is activation of the ADH, and there is also water retention, and there is development of hyponatremia. So hyponatremia in the process of cirrhosis is a progressive, more advanced liver disease, and later then the renal vasoconstriction develops, and that is the mechanisms when there is profound splanchnic vasodilation along with renal vasoconstriction, then that is the mechanism for hepatorenal syndrome, that indicates more advanced liver disease. So when the development of ascites is the step that cirrhosis has become decompensated. A patient of compensated cirrhosis, then the prognosis is much higher, better, the survival is much better. But once the decompensation develop, the prognosis is poor. The ascites is the most important form of decompensation of cirrhosis. The other form is the hepatic encephalopathy and the portal hypertension, the variceal bleed. So about 5 to 10% of patients of compensated cirrhosis per year develop decompensation with ascites. And there is significant impact of life, and the 5-year survival is reduced to 30% when the patient develops ascites. And ascites can be uncomplicated or refractory. When refractory, the mortality is further reduced. So this study that as the year progresses, survival gradually reduces when there is development of ascites. Every year, the mortality is reduced by 20%. So the uncomplicated ascites, the 1-year mortality is about 40%. And development, but 2-year mortality is about 50%. So when a patient develops ascites, then the patient should be referred for liver transplantation, because a patient with a grade 2 or grade 3, other than that, the grade 1 is mild ascites. I mentioned that it is reduced survival, the liver transplant should be considered as the potential treatment option. So how to manage the ascites? The grade 1 ascites, that is mild, which can be detected by only ultrasonography, no need for any treatment. Actually, the natural course is that has not been modified by the therapy. But that is moderate ascites, or the patient is no need for hospitalization. You can treat by sodium. You have to correct the sodium imbalance. The most important is the dietary restriction of sodium. That is the mainstay of therapy, and followed by diuretic therapy. The moderate restriction of sodium intake, that is about 80 to 120 millimole per day, that correspond to about 4.6 to 6.9 gram of salt per day is recommended. This is the guideline of European Association, that is called Study of Liver Disease, the practice guideline published in 2018. And the general equivalent to or no added salt with avoided and pre-prepared meal, adequate nutritional education of the patient is very important. But very strict sodium restriction should be avoided. That will be, food will be unpalatable. And there is no need for bed rest in patients with ascites. And the recommended diuretic, the mainstay of medical therapy is anti-mineralocorticoid drug, because I mentioned informed that there is activation of the renin-angiotensin-aldosterone mechanism, and there is hyperaldosteronemia. And if you block the aldosterone by the anti-mineralocorticoid drug, that is spironolactone, this is the mainstay of therapy for diuretic therapy. And you should start with 100 milligram per day. And you should not increase the dose every day. You should have wait for every 72 hours. And gradually, if the patient is, you should measure the daily body weight and how much urine output is the patient is passing. And then you can go up to 400 milligram per day. But if there is response is not adequate, then you should add furosemide. And you should start with 40 milligram per day. The ratio of spironolactone, when you are adding with furosemide, the ratio should be 100:40. And gradually you can increase the dose up to 160 milligram of furosemide per day. If the patient is not responding to 160 milligram of furosemide and 400 milligram of spironolactone, then we have that the patient is probably not responding to the diuretic therapy. Okay, so that you should do that. What is the daily limit for weight loss? In person with significant peripheral edema, there is no limit. That patient can lose 1 kg, 2 kg per day. But in patient without peripheral edema, the daily weight loss should be restricted to 0.5 kg per day. That is a maximum. Otherwise, there will be hemodynamic disbalance, the worsening of renal functions. Then you have to reduce the dose of diuretic. So daily weight measurement is very important when you are giving intensive diuretic therapy in patients with cirrhosis. So the loop diuretic I mentioned can lead to potassium and magnesium depletion and hyponatremia. So it should be as a combination with spironolactone. The muscle cramp is an important complication. Muscle cramp is an important complication of diuretic therapy, and sometimes it is difficult to manage. So what are the recommendations? Frequent clinical and biochemical monitoring, the maximum weight loss I mentioned, and discontinue diuretic if there is severe hyponatremia, and discontinued furosemide if there is severe hypokalemia. Discontinued anti-mineralocorticoid if there is significant hyperkalemia, more than 6 millimole per liter, and hypokalemia less than 3 millimole per liter. Furosemide should be stopped. So albumin infusion sometimes is necessary when there is significant muscle cramp, and you can treat with baclofen also. The medicines in patients of cirrhosis with ascites, significant ascites, the medicines to be avoided: angiotensin converting enzyme inhibitor and angiotensin receptor blockers should be avoided, because most of the patients of cirrhotic advanced cirrhosis, the BP is slightly on the lower side. And by giving these medicines, it will produce more hemodynamic alteration and worsen the renal perfusion and renal dysfunction. The NSAIDs are contraindicated. Even in aspirin is also contraindicated, other than if there is a significant cardiac disorder with a stented, post-stent, then low dose aspirin is necessary for cardiac disease. Otherwise, you should avoid. There is Vaftans. Actually, it is not recommended. I will discuss in the later that about the management of Vaftans in hyponatremia. Non-selective beta blocker is the treatment for portal hypertension as a prophylactic therapy, and also have the secondary prophylaxis. But when there is significant ascites, and if it is a refractory ascites, you can consider to stop non-selective beta blocker, and you should avoid the carvedilol, and only you can reduce the dose of propranolol. So in some condition, you should not use diuretic. If there is a hepatic renal failure, if there is hepatic encephalopathy, and in patients who have a recent GI hemorrhage, renal dysfunction, then you should not start diuretic, or you should withdraw the start diuretic immediately. And in grade 3 ascites, that is difficult to manage ascites, which is probably not responding to the diuretic, they require the large volume paracentesis. So large volume paracentesis, that is more than 5 liters of fluid is removed in one setting, that is called large volume paracentesis. There may be some contraindication, rarely, like if there is uncooperative patient, or if there is a infection, then you should avoid. But otherwise, it can be safely done, and you can remove. There is no limit for it. Only thing that you have to give IV albumin in the dose of 8 grams per liter of paracentesis. So if you remove 6 liters, you should at least 6 into 8, at least you should give 40 milligram, 40 gram of IV albumin. That is 100, 20%, 100 ml, 2 bottles. If you remove more than that, you have to adjust the dose of albumin. The albumin is much better than the other plasma expanders. So and after a large volume paracentesis, you can give minimum dose of diuretics. So patient may respond after a large volume paracentesis with diuretics. So for fluid removal less than 5 liters, albumin or plasma expander may not be given. It's not necessary. There is no, why you are giving the albumin or plasma expanders? To avoid post paracentesis renal dysfunction, hemodynamic dysfunctions. So when you are removing large amount of fluid from the peritoneum, it produces hemodynamic disbalance. So renal perfusion is reduced, and it can worsen the renal failure. So to avoid it, we are giving plasma expander, particularly albumin. But if you remove less than 5 liters, no need. But you can, if you give albumin, that is better, because albumin has a lot of good effect for in cirrhotic patients, other than these post paracentesis circulatory dysfunction. So, and the sometimes 5% albumin, if there is dehydrated, and 25% albumin is available in US, it is not 20%, but in our country 20% is available. In a hypervolemic patient, most of the patients of cirrhosis, we give 20%. Refractory ascites, that the patient is not responding to the highest dose of diuretic. It can be diuretic resistant or diuretic intractable. Diuretic resistant means that you have given the maximum dose, but there is lack of response to sodium restriction and highest dose of diuretic therapy. And diuretic intractable, there is development of diuretic induced complication, as I have described, that is electrolyte imbalance and other factors. Then you cannot give the maximum dose of diuretic. So that is called diuretic intractable ascites. And the refractory ascites is associated with a poor prognosis. The median survival is only 6 months. So, and so the refractory ascites should be, what is the treatment? The patient must be on intensive diuretic therapy for at least 1 week before stamping as that is a refractory ascites. And if there is diuretic induced complication, I mentioned that hepatic encephalopathy, renal failure, hyponatremia, hypo or hyperkalemia, or intractable muscle cramp. So therapy for refractory ascites is the large volume paracentesis with albumin. Alternative therapy is the TIPS, that is transjugular, intrahepatic, autosystemic, shunt, or rarely there may be some role of peritoneovenous shunt. It is not done almost nowadays. And finally, the liver transplantation. The refractory ascites, and there is some role of the vasoconstrictor drug like this midodrine can be added with large volume paracentesis. And the liver transplant is the finally you should consider patients with refractory ascites. The midodrine is a alpha receptor agonist. It is a sympathomimetic drug. So it is a splanchnic vasoconstrictor. So it is if there is splanchnic vasoconstriction, so it will reverse the underfilling of the splanchnic underfilling is reduced. So it is beneficial for both refractory or recurrent ascites, and even it can be given in hepatorenal syndrome. Usually it is titrated, should be started with 2.5 milligram thrice daily, and gradually the maximum dose is about 7.5 milligram every 8 hours. And you should monitor the blood pressure because the blood pressure may be high. So, but otherwise it is safe drug. It can be used in this group of patients with a refractory ascites or hepatorenal syndrome. That I have already mentioned that repeated large volume paracentesis with albumin, and the tips, that is it is a stent that is introduced and it was at present usually a covered stent is utilized, that is PTFE covered stent, and the stent is through the transjugular route. A stent is placed between the hepatic vein and the one branch of the main branch of the portal vein. And the tips, indication, the tips decompresses the portal system. So immediately it reduces, accelerates the peripheral arterial vasodilatation, and within 4 to 6 weeks improve the effective volumia and renal function, and there is increased renal sodium excretion. So it is recommended that the patient should be evaluated for TIPS insertion when there is refractory ascites and the paracentesis is ineffective. And TIPS insertion is recommended also with recurrent ascites and with refractory ascites, and usually a small diameter PTFE covered stent is better than the used earlier of uncovered stent. After the TIPS insertion, you have to think of this, the ascites is resolution, and then patient may require small amount of diuretic, and salt restriction should be continued. There are some contraindication of TIPS, that the bilirubin should be, if it is more than the 5 milligram, INR is more than 2, CTP score more than 11, MELD score is more than 18, then TIPS should not be done. And also if there is a grade 2 or more hepatic encephalopathic or cardiopulmonary decompensation, patient has significant cardiac disorder, heart failure, in cirrhosis, or there is infection or renal failure. So these are the contraindication of TIPS. The hepatic hydrothorax. What is hepatic? The accumulation of ascitic fluid is getting transferred through the gap into the diaphragm, into the in the lungs, that is called hepatic hydrothorax. So once the pleural effusion develops, the ascites is reduced. So the diagnosis, that the pleural fluid analysis will be the same, just like ascitic fluid, and it is transurative. So, and it is an important advancement in the course of cirrhosis, and onset of hepatic hydrothorax indicates that is an advanced process, and it is an indication that patient should be considered for liver transplantation. Regarding the few points, that the first line of treatment for hepatic hydrothorax is diuretics and paracentesis, that is thoracentesis, large volume thoracentesis. You can remove up to 1 liter or to maximum 1.5 liter fluid from the pleural cavity, but because the more than that produce more dysfunction and respiratory distress, that should not be done like more than that. And you should give the diuretic, and repeated paracentesis should be done. You should not put it the thoracic drainage tube. So it is contraindicated. So the therapeutic thoracentesis should be the treatment of choice for and with diuretic for patients with hepatic hydrothorax. Dilutional hyponatremia. Hyponatremia is an independent risk factor for morbidity and mortality, and treatment specifically for hyponatremia, that if the sodium is less than 120, then you should think of that you have to manage. Otherwise, hyponatremia is very common. So, and if there is a neurological symptoms, and then it needs the immediate management. Otherwise, it indicates hyponatremia that it is an advanced cirrhosis. And you should not correct the hyponatremia rapidly because of the osmotic demyelination syndrome. The fluid restriction should be the first step, and the fluid should be, otherwise in patients of management of cirrhotic ascites, without hyponatremia, no need for any fluid restriction. That you should not give fluid restriction if the sodium is more than 125. Then and if the hyponatremia is severe, discontinue the diuretic, and you also think of discontinue all the antihypertensive medication and even the beta blockers. Albumin infusion is very much effective, and because it alters the hemodynamic. The Vaftans are usually contraindicated, and it worsens the hepatic dysfunction. Though at present knowledge, the Vaftans should not be given in cirrhotic patient with dilutional hyponatremia. And there is no role of hypertonic saline in patient managing hyponatremia in cirrhosis. Just now, my last part of the talk is spontaneous bacterial peritonitis. The bacterial complication is very common in cirrhosis, and the commonest bacterial infection in cirrhosis is spontaneous bacterial peritonitis. It can usually develop in advanced cirrhosis, particularly if there is a high serum bilirubin and high P time, the risk of SBP is high. And about 50% of the patients who are hospitalized for cirrhosis, the SBP has been found to be is a complication for which patient is hospitalized. But sometimes the SBP can be asymptomatic, and you have to suspect it. And usually the ascites is large volume. So the diagnosis, what is the diagnosis? Diagnosis is the absolute neutrophil count that is more than 250. Because I mentioned earlier, the culture positivity is very low. So the absolute neutrophil count, when you are doing diagnostic paracentesis, you should go for the absolute polymononuclear leukocyte count, and the diagnostic criteria is more than 250 per milliliter per ml of fluid. And the 50% of the SBP episodes occur at the patient of hospital admission, and there may be minor, the signs of peritonitis not very common, and there may be signs of systemic inflammation also, and there is worsening of hepatic dysfunction with encephalopathy, there may be renal dysfunction or GI bleeding. So this is that the different symptoms, and I mentioned that about 20% can be asymptomatic. In patients who have a high bilirubin and low serum ascitic fluid protein, they have a higher risk of spontaneous bacterial peritonitis. So this is very important. And the management of SBP, always you have to suspect, and you should give empirical antibiotic. Empirical IV antibiotic should be started immediately in following the diagnosis. And sometimes you have to start the treatment from emergency if you suspect a case of spontaneous bacterial peritonitis in case of cirrhosis. If it is a community acquired infection, the third generation cephalosporin is the drug of choice. But if it is a hospital acquired infection, then you have to think of piperacin tazobactam or even carbapenem, where there is a high prevalence of ESBL producing enterobacteriaceae is the commonest bacteria, but it can be due to gram-positive organisms also. Sometimes if they are severely MDR positive bacteria, gram-positive bacteria, you have to think of combination of carbapenem with glycopeptide or daptomycin and linezolid in areas with a high prevalence of gram-positive MDR bacteria positivity. So the management, whether you should use albumin also in patient with SBP treated with the third generation cephalosporin antibiotic. Albumin significantly decreases the incidence of renal dysfunction and also mortality. So albumin is indicated in managing spontaneous bacterial peritonitis. The dose is 1.5 gram per kg of body weight. That is significant amount on the day one, that when you have diagnosed SBP, you give that 1.5 gram per kg of IV albumin. And in the day 3, you give 1 gram per kg. That will reduce the chance of renal failure, hepatorenal syndrome. And that will reduce the mortality when you are treating a patient of spontaneous bacterial peritonitis. Patient with cirrhosis with a low protein concentration, I mentioned that, and a high serum bilirubin, that has a high risk of development of SBP. And once the patient has developed SBP, the recurrence rate of another, within 1 year, the recurrence rate is about 40 to 60%. This is one study, but if you can reduce by giving prophylactic norfloxacillin to prevent the recurrence of SBP. So that is called secondary prophylaxis. As after a patient who has survived an episode of SBP, the cumulative recurrence rate at 1 year is about 70%. So prophylactic norfloxacillin has been found to reduce the incidence of second episode of SBP. So an alternative, you can consider cotrimoxazole, that is trimethoprim sulfamethoxazole, but it is the most important recommendation is norfloxacillin. So I have not mentioned that also that you can think of primary prophylaxis of SBP. A patient of advanced cirrhosis with a requiring large volume paracentesis, there is no episode of SBP. You can give prophylactic norfloxacillin to prevent the first episode of SBP. So that is called primary prophylaxis for SBP. So this is my last slide. I want to summarize my talk that cirrhosis is the commonest cause of ascites. The diagnostic paracentesis should be performed in all patients with new onset ascites. Serum ascites albumin gradient is the most important parameter in the differential diagnosis of ascites. Regarding the management of cirrhotic ascites, spironolactone should be the first diuretic of choice when the ascites is due to cirrhosis. Refractory ascites should be managed by large volume paracentesis with IV albumin. There is role for transjugular intrahepatic portosystemic shunt in patients of refractory ascites. The liver transplant should be considered in all patients with cirrhosis with grade 2 or grade 3 ascites. The non-steroidal anti-inflammatory drugs, ACEI, that is angiotensin converting enzyme inhibitors, and angiotensin receptor blockers, should be avoided in patients of cirrhosis with ascites. SBP is the commonest cause of infection in cirrhosis, and development of SBP has a poor prognosis and should be treated empirically and on an urgent basis. And I have mentioned that primary and secondary prophylaxis should be considered for spontaneous bacterial peritonitis. Thank you. Thank you all for your patience hearing.
Thank you.
Over to Joyda.
Yes, I am audible.
So,
Yeah.
yes, you are audible.
Thank you, Sujit, for this very nice comprehensive presentation. You have touched all the points. Now I think the subject is now open to the audience for further discussion.
No, you just look into the chat box.
And actually, there are some questions from the chat box. Dr. Dasgupta, please check the chat box, and there are some questions from the person.
Chat box.
Chat box আছে question
Why SAG is low in case of nephrotic?
Yes.
নিচে
Okay, I'm saying I can answer that. Okay.
It is visible to you.
So
yeah, of course, to everybody.
Yeah, chat box.
Okay, you just I have opened the chat box and you just
in nephrotic syndrome. In nephrotic syndrome, you know, there is significant proteinuria. So the serum albumin is low. Then if there is development of ascites, the ascitic fluid albumin is not so low. For that, the serum ascites albumin gradient is not high, it is less. That is in nephrotic syndrome. So it mimics that, it looks like that in a malignant or tuberculous peritonitis. So that is the reason that in nephrotic syndrome, it is a low SAG ascites. The role of other diuretic in cirrhotic ascites like metolazone, torsemide, has been found that the only thing that if the patient develops significant gynecomastia due to the spironolactone, you can think of giving amiloride, but not metolazone, even thiazides, and furosemide or torsemide has no role in managing the patient of cirrhotic ascites. And torsemide has found to be inferior compared to furosemide. So for the diuretic of choice is spironolactone. And if you think that hospitalized patient, you can give a combination of furosemide with spironolactone. How long should propranolol be given in patients in the grade 3 esophageal varices? In patients of esophageal, when you are managing the patients for portal hypertension with esophageal varices without ascites, propranolol should be continued lifelong, that as the patient will be living, because that is the most important you are giving either for primary or secondary prophylaxis. But development of ascites, that is called the window period, that when there is you are giving the propranolol in a beneficial, you all know the non-selective beta blocker are beneficial for managing the portal hypertension in patients of cirrhosis. But when there is significant, large volume, the patient is intractable ascites, the BP, the blood pressures, the cardiac output is reduced. And giving propranolol can do more harm. And there are some data that giving propranolol in this group, the mortality is high. For that, it is recommended that you should reduce the dose of propranolol, or sometimes you can avoid. So if you further reduce the cardiac output, and then that will reduce the renal perfusion, that will worsen the renal failure. So that will precipitate hepatorenal syndrome. So for that, it is recommended that carvedilol should be avoided and propranolol should be reduced, and the maximum dose should not be used, and you should titrate, and if possible, you should, according to the MAP. The MAP should be more than 90. If it is less than, the prognosis is high, mortality. If it is less than 80, it is high. So when you are giving beta blocker in patients of advanced cirrhosis with ascites, you should measure the MAP, and then you should titrate. But that at present, the propranolol should not be stopped. There are many advantages other than hemodynamic alteration of beta blocker. It reduces the bacterial translocation. The bacterial translocation is the main mechanism for all the dysfunctions, organ dysfunction in cirrhosis. So bacterial translocation has been reduced by propranolol. Pancreatic ascites and cirrhotic ascites, and there is evidence both, sorry, I cannot, CLD and paracentesis. So if a patient has, I have mentioned about 5% of patients have a combined, that is cirrhosis with another cause of ascites, and commonly tuberculosis, or rarely can be malignancy. But in a case of cirrhosis with pancreatic ascites is not a it is very rare combination. We know that alcohol can produce cirrhosis, alcohol can produce pancreatitis, but very rarely it is said that the advanced liver disease and advanced pancreatic disease combination is very rare due to alcohol. But okay, as you have asked, it is possible. Then only thing that the most important test of pancreatic ascites is pancreatic fluid amylase. That will cleanse the diagnosis, and pancreatic ascites, the protein is high. So it will be a low sag ascites. And if a patient with a known case of cirrhosis, if you suspect, then you should go for amylase and you should calculate the sag. There is a question for management for malignant ascites. The malignant ascites, I have already touched it, that you should suspect clinically, there even from the physical examination, then imaging, that is ultrasonography, then the CT scan, then the ascitic fluid study, then the most important, the ascitic fluid cytology, that if the malignant cells is positive, the sensitivity and the of these diagnostic test, it varies, and sometimes you have to go for repeated test for for when you are suspecting malignant cells. The specificity is 100%. It cannot be less than 100%, but sensitivity is in the tune of 50, 70 different studies, not 100%. So when you are suspecting, and sometimes you can give more than 250 ml of fluid, so that will be centrifuged, and then from the centrifuged material you can do the stain, and you can do for the even cell block, you can go for cell block also. So these are the approaches. But even then, if the IBD was suspecting, then you should go for peritonioscopy and biopsy. And the same for tuberculosis. If the other parameters, like you cannot detect by the ADA, there is borderline, and also that the other parameters are you are suspect that, but you cannot. But in our country, but in our personal experience, when a patient is coming with ascites, and then the protein is very high, the cell is around 400 and 500 total WBC count, and the neutrophil is more than, lymphocyte is around more than 80 to 90% is lymphocytes, and the ADA is 50, 60, then I think that you can start the therapy with empirically. There is no need for peritonioscopy and biopsy. But the patient is not responding to the medical empiric therapy with anti-tubercular drug, and then you are suspecting, you cannot differentiate whether it is malignant or tubercular, then peritonioscopy and biopsy should be done. Actually, there is a question that primary prevention of spontaneous bacterial peritonitis, I have not showed in the slides. Actually, I mentioned it. You know that there is, that when the patients of SBP develop in an advanced cirrhosis, so, and patient in the background, there is a large ascites, huge, significant ascites. So, if there is renal dysfunction, the patient is bilirubin is high, so that indicates the MELD score is high. The patient with a high MELD score, these are the patients who have a candidate for transplant. The MELD is more than 18, 17 or 18, with a bilirubin high, INR high, and MELD Na, that is sodium is low. These patients, there is chance of infection is very high. Then it is that you can think of primary prophylaxis of SBP. But problem is that the norfloxacillin, it is a quinolone. You know, in our because of the quinolone resistance is we don't know the quinolone resistance probably in our community is significantly high. And all of us have experienced that in an acute diarrhea due to infection, at present quinolones are not recommended and quinolones are not effective also. So due to some Shigella or Salmonella infection, quinolones are not effective. So for that, at least the Western data in our country, we don't know what is the data, whether it is norfloxacillin is sufficient to prevent the secondary prophylaxis in our population of cirrhotic ascites. We don't know. We are using, but we should have our data that whether it is norfloxacillin is effective or not. So that is very important. Dr. Dasgupta, any questions from the, can you, that I have missed it? MRI is not more sensitive than CT for intra-abdominal pathology of any type. That is common for, so if MRI is not more sensitive than CT for intra-abdominal pathology, I don't think that MRI is more sensitive, because you know that but MRI is more expensive, but otherwise you have to do, when you are doing a CT for evaluation of ascites in either you want to do that in cirrhosis or malignancy or tuberculosis, it is equally sensitive and specific. That contrast MRI you have to do, and when you are doing CT you have to do the contrast CT. With that, non-contrast CT has no role in the evaluation of any intra-abdominal pathology. But MRI is more expensive, and for if the patient has some problem with contrast CT, then it is, you can use MRI, because mild renal dysfunction, MRI can be done, but CT should not be done. So otherwise, the MRI and CT is comparable for evaluation of intra-abdominal pathology. It is CT is more easily available. It can be done very rapid, in a very short time, and I think that CT should be the first step. But if you want to know that wall thickening, bowel disorders, inflammatory bowel disease, then because you know that you are when you are suspecting malignancy or you are suspecting the hepatocellular carcinoma in cirrhosis, the CT, the contrast CT, that is called triphasic CT, should be the first step.
Joyantudha, if there is no question, you can wind up. Dr. Dasgupta.
Dr. Dasgupta left, sir.
If there are no questions, then
There is one question I want to touch, that is the management of coagulopathy in cirrhosis. This is very important. And you know that yesterday there is I had a meeting for that is there is a lecture on the digestive disease with DDW. The best of DDW has I was hearing it. So the portal vein thrombosis is an important complications of cirrhosis. You know, in cirrhosis is a condition when there is a coagulation dysfunction, and also the thrombolytic system is also dysfunctional. And the development of portal vein thrombosis, other than cancer, that is hepatocellular carcinoma, can have a complication of portal vein thrombosis because of the tumor is spreading into the portal vein. But per se, cirrhosis is also a condition of hypercoagulable state. For that, the incidence of portal vein thrombosis in the process of in the course of cirrhosis can be up to 5 to 10%. And you have to suspect, particularly if there is worsening of ascites, the patient has developed suddenly the deteriorating ascites is not responding, and you do a CT and you found that there is a thrombus in the portal vein. Then immediately you should start the anticoagulation. So anticoagulant should be given when there is any thrombotic complications of cirrhosis, and the safety profile has been established. Even the NOACs or DOACs can be safely given in cirrhotic ascites. Initial recommendation was low molecular heparin followed by warfarin, but at present the DOACs, that is direct acting oral anticoagulants, are recommended in patients who develop some thrombotic complications of cirrhosis. But I am reiterating, if there is any patients of cirrhosis with a high p-time, low platelet count, minor therapeutic procedures, even the paracentesis, there is no indication of prophylactic FFP or platelet transfusions. But in patients who are requiring large volume paracentesis, but if the INR is very high, if there is any bleeding manifestation, if there is renal failure, you have to be very cautious. If the INR is more than 4, that indicates that it is a severe coagulopathy. But in cirrhotic, INR may be 1.5, 2 maximum, not more than that. If the INR is more than 2.5 or 3, particularly in patients of alcoholic hepatitis in cirrhosis, we used to see that INR is very high. And for doing large volume paracentesis with wide bore needle, there is yes.
কার বুলডগ ডাকছে?
To reduce the dose of
Yeah. All these drugs are metabolized also in the liver, and if there is renal failure, also there are some implication you cannot use. So in patients of child C cirrhosis, when you are really thinking of giving drugs or NOACs, then you have to think of the dose response, the dose and the safety profile also. But only thing, a patient who has developed, because you know that a patient who has developed portal vein thrombosis, not only the course of the liver disease is altered, that is a worsening of ascites and others, and also if you think that patient needs to be transplanted, if there is a portal vein thrombosis, the transplant will be difficult. And for that, if you give the oral anticoagulant, that will recanalize the portal vein. And the chance of recanalization by early detection of portal vein thrombosis by giving the anticoagulant is to the tune of 80 to 90%. So that is also important for the management of liver disease.
One more thing for the PGTs, that clinically there is a one particular cardiac condition which we call the constrictive pericarditis, usually presents with ascites. A patient with not so much cardiac findings and the ascites, there is a very important clinical issue that constrictive pericarditis usually presents with ascites. That's the PGT.
And thank you, Amulda, for raising this issue. And I've touched it, but I have not emphasized it. So, but this is the most important curative cause of ascites,
Yes.
the treatable cause of ascites.
Yes.
So always you should suspect. You are doing ascitic fluid study, lot of sag and everything. You cannot find what is the cause. You are confused that because it is a cardiac disease, it looks like the sag will be like cirrhosis. So so you have to have a strong suspicion that whether you are missing a case of constrictive pericarditis. So you should do the echocardiography, when cardiac CT, and even if necessary cardiac catheterization, everything you should suspect, and it is a curable cause of ascites.
Ascites with the engorged neck vein.
That is obvious, but that is sometimes it cannot be shown, where you have to be very that you know that the engorged neck veins is a clinical finding and you should not miss, and always you have to be, but sometimes you know that maybe